Alrighty, I think we're here. I'll just,
Do you want me to
well,
be next to you or not?
I don't mind. I don't have personal space issues at all. Literally, we do this for a living, right? Like getting in this close. Okay. Hi, everyone, in person here and online. Thanks for joining us. This is a rather special event for Flex Physio team. We've got both Hannah and Robyn Hickmott coming in today, and they're presenting on hypermobility. Well, Robyn's presenting on hypermobility, and Hannah's going to be discussing and being questioned, if you like, around her journey and experience living with Ehlers-Danlos syndrome. Hannah's special to us at Flex and part of the family here. She's been coming into the practice early since before I started here. Yeah, 2008. I started here in 2012. So we're going to run through an update on hypermobility with Robyn. I hope everyone can see the slides there. I think that's up. And then we're going to be having a bit of an interview and Q&A session between Robyn and Hannah and myself and Ian and everyone else who would like to join in. As a courtesy to the presenters here today, or Robyn and Hannah here today, it would be great if people could show the video online if you're not otherwise eating, getting changed, or sick. And that way we can see everyone's faces who are attending. Feel free to mute yourself when you're not speaking, and otherwise unmute yourself if you do have a question. Would you like to save questions at the end? Or
I'm happy if you can direct if people want to ask questions.
Yep,
so
the during is okay.
Yeah,
Yep, so asking questions throughout is okay. We probably would prefer having questions through the microphones where people are rather than in the chat, but if necessary, you can write the chat and I'll ask the question for you. Alrighty, can everyone see the PowerPoint online there? Yep, wicked. Okay, we'll get started in that case. Thank you very much, Robyn.
Okay. Great. Hello, everybody. It's lovely to see so many faces that I recognise online, as well as met some new friends here today. Now, I just have to figure out, Jay, how to get to the PowerPoint, because I've got all the people's faces here. Oh, I know. Sorry. No, it didn't work. Just tried to minimise that.
It's probably because I have you on Zoom. From now on, you can just push forward.
I just can't see it on here.
Oh, did you want to see it on there?
Yeah, if I could see it on there, that'd be great. Perfect.
Is that okay?
Yep, that's good. And then I can just run the videos from there.
Yeah, absolutely.
Have you got control as well if the videos don't work or not?
No, not at all.
All right.
That'll otherwise be me moseying on over here and help you.
Let's make a start. So my intention today is to raise awareness and to help answer any questions that you might have about where we're at with hypermobility and EDS. So we know how common hypermobility is now, and we know that the prevalence is a little bit controversial depending on which country you live in and what studies you read, but there was a review that I'll mention later that came out in 2022 that gave these statistics, so I thought that that was good enough for me. So we know that it's a spectrum influenced by age, gender, ethnicity, and environment, and that many people with hypermobile joints remain asymptomatic, and that this is incredibly advantageous in sport and dance, and those patients certainly don't need to be medicalised. But joint hypermobility can also indicate more widespread issues involving the connective tissues, and that's what we want to talk about today. So in 2017, there was a review by the EDS International Consortium of all the different types of EDS, and there was the introduction of the hypermobile type and also the hypermobility spectrum disorder. So they're the most common that you'll see. There are 14 types of EDS. And I just put the picture of one of the journal articles there just to show the difference between in the skin scarring of the hypermobile type. So there's like an atrophic scarring that you will see that is common after surgery. So a lot of our patients who've had the orthopedic surgeries will actually have scarring like that. But next level of tissue fragility is seen in the other types of EDS, like classical EDS, which is shown there. So we now have this spectrum where on the far left of the spectrum, we have asymptomatic peripheral joint hypermobility or localized joint hypermobility. And we don't know what percentage of patients that is, but it certainly is quite a few. And then we have people that meet the formal criteria for generalized joint hypermobility. And then we have people who may show symptoms that are related to that. So they may have an injury, or they may develop pain or fatigue, or any of the other comorbid symptoms that we're going to talk about. Then on the far right, we have EDS, the 14 types. And most of those other types are really rare. So 1 in 40,000, 1 in 20,000 for the vascular and for the classical. But the hypermobile type would probably make up 95% of the EDS types. And it is unfortunately the only one that does not at this stage have a biomarker. So they have not been able to yet find the gene or genes that may be responsible. But part of the process that has gone on over the last few years is to actually create a diagnostic criteria to be able to genetically test those people. And that work is ongoing. So what I want to do is give you lots of resources. So this is probably the go-to website where you can find, if you want to delve more into the genetics, you can. If you want to watch a video on exactly how to do the Baton scale, you can. All of the types of EDS have actually got a paper on them in 2017. So there's an easy link to that as well. And then if you're a patient, there's also lots of information too. I thought I'd put the diagnostic criteria in, not because I'm going to go through it in detail, but because at the very top of it, it actually does have the cutoffs that we use at the moment. So to meet a criteria of generalized joint hypermobility, if you're prepubertal, you have to have a Baton score of 6 or greater than 6 or more. If you're between puberty and 50, it's 5. And if you're older than 50, it's 4. There's also on the top of that, the Hickmott 5-point scale, which is actually a really useful tool clinically to use with adults who may have lost some of their hypermobility. So if somebody answers positive to 2 out of 5 of those questions, then there's a high specificity and sensitivity that they have got or did have generalized joint hypermobility. And that, if you're looking at the formal diagnosis of hypermobile EDS, that can actually give you another point if required. But the diagnostic criteria is generally done by the medical people because, as you'll see in the part B, is they actually have to qualify the state of stretchiness of the skin. So stretchiness greater than 2 centimetres may, in some literature actually be significant. So it's a little bit subjective, is, unusually soft or velvety skin or mixed skin hyperextensibility. But the whole criterion B is to really look at the multi-system comorbidities. And then obviously for the third criteria, you actually have to exclude other types of EDS and inflammatory arthritides and any other sort of concerns. So in 2017, the EDS International Consortium actually published all this data, and behind the scenes there had been this working group, physiotherapy working group from all over the world. And the key people that were in that initially were, Verity Pacey from Sydney, Jane Simmons, who I met when I was working at Royal Perth, and some of you may also have known because she did her training here as a GEM student at Curtin University, now works in London. And then there's a very strong research group in Denmark and they actually, behind the scenes, came up with this international consensus on the rationale for what physiotherapy should look like. And then the Working Party has gone on to produce work. In 22, there is this International Perspectives on Joint Hypermobility paper that was, you can see the names there, Leslie Nicholson, Verity Pacey, Clifton Chan, so big Australian sort of focus there, very strong with the paediatrics. And then there has also been a review that came out last year that is a review of the paediatric framework as well. On the right, this may be of interest to those who are working with very complex patients, the upper cervical instability recommendations. So that was presented at the APA conference last year, and there's a strong Australian focus in that as well, and Julie Treleaven as well. So this infographic, I think, is quite nice. It's from Leslie Nicholson and the working group's paper. It just shows that hypermobility can be what we see. It's the most obvious form and it can be totally asymptomatic, and people may have incidents of dislocations or subluxations, and they may not have any of the multi-system features. But if you look at the iceberg on the right, you can actually have much more of a problem. You can actually have comorbidities that we're going to talk more about. And at the far right bottom is more the red flag. So the extreme tissue fragility and orthopedic concerns. So I can't read those out because it's too small for me, but anyway. Also just there's been some confusion since the 2017 reclassification came in, but we know that joint hypermobility is really an objective measure of a joint moving passively or actively beyond the normal range. So beyond the 2 standard deviations of the norm, if you think of those curves from statistics and physics. And laxity is the measure of a joint to move passively beyond normal in an accessory sort of plane. Okay, so that's your Lockman's and your anterior draw. And joint hypermobility and laxity can be extremely normal if there is no pain or injury. So I think it's really important to know that. But functional instability is the self-report by the patient of mistrust or insecurity that their joint will remain intact even under low load conditions. And that the patients might describe that the joints are subluxing, going out of place, giving way, or frankly dislocating. So just to talk a bit more about the multi-system involvement, because that's what we really want to raise awareness of. 2/3 of patients with symptomatic joint hypermobility report GI dysfunction, orthostatic problems, urogyne concerns, allergies, mast cell symptoms, physical and cognitive fatigue, and mental health concerns. So we know that there's associations, but yes, causation is not proven because we know that there are patients that will present with these concerns who are not hypermobile as well. And often patients are very deconditioned, and these issues can be a problem just with deconditioning, some of them. I'm not going to read through that whole list, but I just wanted to give you more information because this can affect body systems in so many different ways. So it's a chart that you can refer back to if you're wanting to look for things. I would probably just draw out the hyperalgesia that is being proven to be present in adults and children who are symptomatic with their hypermobility, so have pain, because I think that that's really helpful when you're explaining pain to patients. And the growing association with the neurodivergent. So Jessica Eccles she's in Bristol in the UK, is a neuropsychiatrist who's really doing lots of fascinating research in this area. And we currently know, and I'm sure we'll have more information in time, that people with hypermobility are probably 4 or 5 times more likely to get a diagnosis of autism or ADHD or Tourette's or dyslexia during their lifetime. So there is an outcome measure specific to hypermobility, which has been around for a couple of years now. It was Professor Shay Palmer's work from Bristol, and it's useful, and it really does measure the psychosocial impact that hypermobility can have on somebody's life. So it's about 4 pages. It probably takes about 10 to 15 minutes for a patient to fill in. You can actually put it on PhysioTrack and actually email it out to a patient in advance and add a few questions about, I've added questions as to what patient might be expecting from their consult, and it's really quite helpful. In terms of the multi-system things, there is now the spider. So we've always used, you'll see the case study that I'm about to give, we've always used the spider clinically, but now it's about to be released in the next week or so. All of the arms of the spider have now been validated in adolescents, so 13 to 18-year-olds. So it, once again, takes less than 10 minutes for the patient to complete. It measures the impact of their multi-system comorbid conditions, and it can actually just give you an idea of what the biggest problems might be and if they need referral on, or sometimes the interconnectedness between those domains. And there is an app as well. So I think it will actually probably be, hopefully patients may even present having done that because it's so easily accessible for them.
Are you going to talk in a minute about what the arms of the spider are?
I was going to do that with the case study. Yeah, cool. So this is some medical professionals might say, well, there's no treatment for hypermobility. I think what they might mean is that it's very individualized as there is such a spectrum of presentations. This is just one that has been purported in the research. So we want to make sure we do manage any systemic comorbidities and educate. We want to make sure we decrease the sensitization that we know is there. And then we want to get into the things that we all do every day. So we want to problem solve from a joint perspective. There's research that shows that people with hypermobility have very poor proprioception. So that can be a challenge at times. So often they will do well with sensory input in their exercises. And also they often have a lot of overactive muscles guarding their joints. So it's a matter of actually being able to diagnose that and treat that as well. And then obviously stabilisation, strengthening and aerobic conditioning and education about flare management, which is vital. Now, you'd be glad to know I'm not going to go through all of that, but in some universities, they actually do have units on hypermobility and all of this. And so this is an example of what is taught at Clarkson University, and Professor Leslie Russick has actually made all of this available for free online. And I don't really know how she's done that, but it is America. So, you know, I've given you the link because I think not only she also works privately, she has also given all the handouts that she gives to patients, and she's made them available too. So go figure. Now, this is actually something that came out last year. It's by Dr. Linda Bluestein is a sports medicine doctor in America. So she sees a lot of dancers, and she's come up with, her research team have come up with this sort of treatment strategy, which is, you know, I find it quite nice when you've got the multi-system component. So the articles that she has published are called Hope for Hypermobility. So there's one that focuses very much on pain and the other on treatment. So I've given you the reference for that. So it's actually day law. And there have been times when patients ask me about supplements and things like that, that I actually just email them these papers, which are freely available on the internet. So I think it just gives them more information of things they might want to do. I was just going to quickly go into the case study, but if there's any questions that anybody has. It's a lot of information, I know, it's too fast, hey? Okay, so.
Sorry, there was a query about the previous slide. Okay, I didn't mention earlier, thank you, HE163455. I think you're probably a health employee.
Okay.
There will be the slides sent to all people after the presentation today, so you'll have access to everything.
Thank you. Sorry, this is just a team of physios at Royal Perth Hospital.
It's you, Jane. You know.
I put us on off video because we were eating.
That's all right. Thank you, Jane.
Thank you very much.
So when the EDS Society came here in 2018, and I reached out to Ian and we collaborated on a case study, a few case studies actually, and one of them happened to be Hannah, who at that time we called Nicole. I don't know why we did that, but anyway. So this was the format that we used, the ICF International Classification Functioning. So I won't go through and read this out, but basically at that time, Nicole had not been diagnosed with hypermobile EDS. We knew that she had generalized joint hypermobility, and we knew that she had pain. We knew that she was dizzy, and that she had some urogyne concerns, some IBS, and that she had trouble with tasks with her hands. She would interestingly sit down to wash her hair. At that time, in terms of outcome measures, the ones I've just mentioned would have been fantastic, but we were looking at quality of life, self-efficacy, Arebro, and hand function. And this is the spider. And so basically at this time, we were actually just getting a subjective, we're just saying, you know, how do you feel these symptoms are impacting you? So now that the spider has been validated, there are set questions that have been proven to be indicative of dysfunction. But I actually remember interviewing Hannah and her mum and actually just finding out how they felt that was presented in childhood. So obviously there's those domains. The mast cell has been left off the validated questionnaire because there just isn't enough research at this stage to link that. But there are papers, actually, I didn't reference that, but there are papers that put together that case. We'll talk a bit more about that at the end.
Robyn, can you just elaborate a little bit on what you meant by mast cell?
So mast cell activation syndrome is a term which is used to indicate that there might be problems with the immune system and an abnormal mast cell response. Okay, and so because our mast cells are proliferate throughout the body and in our connective tissue, one can probably understand that in somebody who's got stretchy connective tissue, they may be, you know, more influenced by things like vibration, trigger, heat, things like that. Patients that might have rashes, patients that might have gut problems, we might be suspicious of that. But that's actually quite a tricky one at the moment, and I'll give you a little bit of evidence-based information about that at the end. In adolescence, this is what happened in terms of the spider graph for Hannah. The presence of the dysautonomia, which is very, very common. The POTS, I think the main age that peaks in girls is 14. So I think in any of our teenage patients, it's always good to look out for that. And then in adulthood, when Hannah had just turned 20, oops. Oh, yep, all right, so we did adolescence, infancy, and at 20 years, and then we have actually got an updated one shortly. So one of the first things we did with Hannah was just to actually get more information about whether she maybe had some POTS. And this is just, you know, the quiet standing test that you can do. There's now POTS Australia that's got information on it that, you know, it helps patients to do this themselves. They're very capable of doing it with their Apple Watches and everything. And what we saw with Hannah was that as soon as she stood up, immediate colour change. And probably what was most interesting was that she was symptomatic. So even though her heart rate didn't increase over 30 beats per minute, it did increase 29. Obviously, there were implications for her in remaining upright. And I remember at this time, Hannah was on prac. You know, she was upright for long periods of time. So I'm just not quite sure how she managed to do that. I think she did have a few collapses, actually, didn't you? Yeah. But if people are going to be formally tested, I believe, and other people would know more, that in using a tilt table, you're strapped in. So, of course, you actually wouldn't be using any muscles at all. And so you would probably be elevated. But I always assume if people are symptomatic like this, that they have some form of dysautonomia. And that needs to be discussed and a good plan made, because it ties into their fatigue and often their gut as well. This is just the management of POTS. So there's plenty of information out there on the net. That's just one reference for you. With Hannah, we just tried to actually integrate some of her motor control type exercises with a little routine that she did in the morning. So basically lower limb circulation exercises before one would get out of bed, keeping hydrated, supine exercise generally, and then there are many treatment approaches for cardiovascular training with POTS. We'll touch on that at the end as well. Okay, so this was just some other information about Hannah. So we found that the first picture there, I remember asking Hannah to actually stand at your worst. So that was Hannah at her worst, which was actually not that terrible at all. But she had the classic sort of sway back, the centre of gravity way back. If you're actually looking from the lateral malleolus up, there's a lot more of her body weight in front of that imaginary line than behind. She certainly was weight bearing more on her toes. Her knees were hyperextended, but she had surgery, so she wasn't actually as hyperextended as she perhaps used to be. Some protraction, forward head, but when I actually said correct, she did so beautifully. That's because she was well known to flex. In terms of, this was what we showed in terms of skin stretchiness. So we often would look at in the arm, inside of the arm, back of the hand or the neck. And then just the scarring. So this was from Hannah's patellofemoral alignment surgery, and you can just see the quality of it is very typical of the hypermobile type. and pysiogenic papules, they're barely there, but they are there. I don't know if they're more there now, a few years on. Yeah. So, you know, they're very, very mild, but they are there. So I tend to think of the pysiogenic papules as like failure of the fat pad that we have. So we've got a fat pad under our heel, but obviously with the fascia not being strong, you actually tend to get the fat sort of coming up with impact, basically.
So that's that little lump that you see there, the little white thing. Yeah.
Yeah. If you Google pysiogenic papules, you will find some, you know, in some of the rarer forms of EDS, some incredibly shocking pictures. Actually, they can be really quite, not that Hannah's going to go on to develop that, it's just that sometimes that can be indicative of just how lax the connective tissue actually is. So when we did more of a postural muscle length assessment, we found that Hannah's hip flexors were long and weak, and that is a very common finding and gives you somewhere to go with treatment in terms of wanting to really improve her inner range hip flexor strength. She'd always had tight hamstrings, a little bit unusual, but perhaps related to her surgery. I don't know, maybe Flex can comment on that. Her rectus femoris was very long, but did feel tight, and that's really common with our hypermobile people. They might actually have, you know, excessive range of movement, but they feel tight, and calves were long and weak. So just in terms of rehab, I mean, Hannah had done a lot of rehab, but obviously when we were giving this case study, we just wanted to show that we would want to start with closed kinetic chain exercises, proprioceptive exercises, and there's some examples of that, and progressing to open chain. And Reformer is a useful piece of equipment just because of the ability to really work on the lower limb and the, you know, if there's POTS, it's actually really good. We want to always strengthen the calves and the quads and the glutes to help with venous return. And obviously with the jump board, you can actually start to get some of that nice loading without the body weight. Okay, so, oh yeah, and whole body exercises. So stretching, you just want to be really careful. You don't want to stretch the joints necessarily. It's obviously it's individualized as to what's tight and all, but you do have to come up with some creative ways of releasing tone in muscles that often are overactive. So there's just some examples that we used at that time, and some take-home messages for prescribing exercise. The goal is for patients to be confident in their body and to be able to self-manage pain flares. Mindful moving and breathing integral to that. The muscle and aerobic conditioning is obviously, it's easy to say it's the mainstay of therapy, but it's not that easy for the patient. And, you know, is fear of movement dominant? It certainly wasn't in Hannah's case, but, you know, we have better ways of assessing that now. The questions on the Bristol Impact, the last 5, which I screenshot, are actually really good at just picking up, you know, how fearful people are of movement. Is there some degree of POTS that's not been, you know, recognised and addressed? And, you know, stretching and release of overactive muscles needs to be done carefully. Pacing, super important. We'll talk more about that later. Start with gravity eliminated positions, closed kinetic chain, inner and mid-range. Our dancers might need to work throughout their whole range, but some of our patients who aren't dancers or athletes may not ever need to go into their full range. But there was some interesting research that Verity Pacey did in Sydney that did show that the patients that they actually exercised children into their hypermobile knee range, and they had a group that they didn't. They got them to stop at 0, but the patients that exercised throughout their full hypermobile range and developed control did better psychologically. So yes, the goal might be to end up working at and getting control through your whole range, but with some of our very deconditioned patients, we may not ever get there. And then there's always a lot of you know, problem solving that we all do on a daily basis about, you know, with the hyperalgesia, but also with weight bearing through our hands. So people often, instead of being like this, might need to be in wrist neutral, things like that. Even wearing gloves for exercise. Now, this was the new spider that we did. So you'll notice that the mast cell activation arm has gone. And they are actually located at different spots. So on the left, this is what Hannah filled out for me last week. So we're actually seeing this is how on the validated questionnaire her symptom profile came up. So pain and fatigue being dominant, dysautonomia being dominant as well, some low-level anxiety. And then I also asked her to actually just do another one that tracked the impact of those things on her. And so I think that's actually really quite useful information. So the fatigue being the strongest one. Anyone want to make any comments about that? Yes, Jay?
Do you see much relationship when using these spider plots or radar graphs in particular between fatigue and the mast cell component?
Yes, so it's a good question. Having been involved in ECHO, where you do get a lot of case studies presented internationally, usually, though, when mast cell is addressed, you often do see improvement in fatigue. It's anecdotal, but yeah. Okay, so this is really messy and busy. The black is, at the time in 2018, what we in our case study workshop actually said we would suggest for Hannah. And then the red is really where we're at now in terms of current research and evidence. So I'll start with the fatigue, because that is, I mean, we're not trying to give individualized advice here, but the fatigue is a very common big player. And I just wanted to let you know of a couple of advances. So ADAPT is something that I think we'll probably hear more about. It's Jessica Eccles, the neuropsychiatrist in Bristol, has done one RCT on this, and it's actually, they did it through COVID. And so the paper describes that instead of people coming in and doing this therapy, which is a biofeedback therapy for heart rate, they actually did it via iPad. So basically it's a down training of the autonomic nervous system, which, you know, you can understand how that might be helpful. So that will become available at some stage in the future, I'm sure. So watch out for ADAPT. And also in the research, sleep apnea assessment is recommended because it is well documented now that there is a higher rate of sleep apnea, and that can of course impact fatigue. Okay. So in the psychological domain, we've got just that, you know, how the greater recognition of the neurodiversity can impact ability to comply perhaps with treatment programs, but probably also the interoception and pain processing. So that research, it will be interesting to watch. And breathing exercises. So at King's College in London, there is a respiratory physio called Riley. And I've given you one of the references there, but I think it's a he, I'm not 100% sure. They have actually published on breathing exercises for POTS, and shown that 15 minutes of breathing daily, where the focus is basically on 2 in, 2 out pause for hyperventilation or just dysfunctional breathing, is as effective as medication for POTS. So I think watch that, because I think that's actually really important work. And I think the reference I've given you there is they have gone on to develop an assessment tool, which is being used to assess dysfunctional breathing in people with POTS and hypermobility. In terms of POTS programs, there is plenty out there. There's the Levine program, the CHOP program. They're all pretty intense, and you know, they're easily available on the internet. I think if you've got an athlete who's come from a high level and then they've struck down with POTS, it would probably be a reasonable path to train them in that way. But there is a big trial that's being done at the moment in the UK called the PULSE trial for POTS, because POTS has obviously been a comorbidity of long COVID. And what they're focusing on and what they think is easier for patients is just using the RPE scale rather than heart rate to actually determine when to progress them. So just low level, you know, so you might for the first month with people just be working at light. So, you know, anything up to 6 on the RPE scale that goes up to 20, and actually progress people that way. So apparently Apple Watch has a POTS program, I believe. And then there's all the HRV training, which, you know, if somebody's quite technological, that might really appeal to them. And Leslie has got handouts on how to do that on her university website. The gastrointestinal, because that's such a big area, it's sort of outside of my scope perhaps to be, talking a lot about that. But what I do is just really give patients the Daylor, which is the Linda Bluestein dance medicine lady, give them that article, because she talks about extrapolating on evidence from other conditions, and she recommends that there is a higher need for vitamin C, magnesium, B1, 2, and B12, vitamin D, fish oil, other things like that. So it's not me saying that that might be helpful, it's somebody else, and it's up to the patient what they might do with that. I know with the symposium we had Heidi Collins come over, so there's a lot of information that she's got on the net about diet as well.
Sorry, Robyn, just two questions on that. There was a question from online here around, is there a higher prevalence of celiac disease in people with?
It is reported, but it's unclear as to whether that's because people are symptomatic and they get tested more.
Yes.
But the thinking is that, yes, there is. And there's also a higher rate of food intolerances and IBS.
Yep.
And low histamine diet is the other thing that's probably been recommended.
And the other question, I guess, was there was that person that you mentioned with all of the vitamin that talked about the vitamin supplementation. Is that in presence of blood tests that indicate they're lower? People are lower in that, or
no, it's just anecdotal evidence
sure.
that this doctor has found in her clinical practice in America working with dancers.
Yep, fair.
So,
thank you.
And then the Weinstock article, I think, is at this stage, I don't know of a better article about the gut and mast cell. So it's actually called a primer for the gastroenterologist about mast cell activation disorder. Now, if when I speak to patients, they're quite disabled with their gut symptoms, and that actually comes up as the strongest thing on the spider, then I will give them that article and actually say at the back of it, there is actually a mast cell questionnaire, which they can fill out and take to whichever doctors they are seeing. And it actually also goes into what treatments are available for mast cell that often some of them can be done without prescription. So it's somebody else's work that I'm giving them. It's not me telling them what to take or what to try, but that's as good as I can do at the moment. But you'll certainly be hearing more about that. Oh, so actually we didn't do the left side, did we? So in pain. So I don't know if you've heard, there's a researcher in University of Sydney or Macquarie University, anyway, somewhere, called Mincy, I think. And they're just completing this Hope Online Pain Ed program for patients with HSD and HEDS. So I believe that those results will be published soon. Other people who are watching might know more about that. The Young Pain Health website is fabulous. That came out last year. If you haven't looked at that, certainly have a look at it. Curable, often recommend that to patients. Feedback is mixed, but it's good information. And then in terms of the neuromusculoskeletal, there's a review, quite a critical review actually, but that's what evidence is, isn't it? So the Burke one about all of the exercise and rehab studies that have been done for EDS and HSD. And, we don't have a lot of great evidence, to be honest, but there are a lot of people working really hard on this. And so there will be more that comes out. But there is some evidence with hypermobility for knee exercises, Pilates for trunk stability, proprioceptive exercises, how important they are. Shoulder, there has been, the Denmark group are really strong on shoulders. And so in a couple of slides, I've actually just got some information about that. But what they have found is that for multi-directional instability of the shoulder, they've done a RCT where they've actually had a low load approach. So more starting off with isometric exercises and then another starting more with resistance and weights. And initial results showed that the high load came out better for pain and function. But I think the 2 and 3 year follow-up are showing no difference between the groups. But that's actually really important information for all of us. The Zebra Club, there's a Pilates instructor in London called Jeannie DeBon, who's got a free YouTube channel. And the Zebra Club is actually an app which I often recommend to patients because we all know how expensive ongoing treatment can be. And for some people, that's just not viable. But the Zebra Club is actually got sort of your one-stop shop for pain management, mindfulness, dealing with flares, proprioceptive exercises for every joint of the body. And they've got a good medical board. So Leslie Russick is involved. I think she's the medical advisory person for that. And it's worth checking out. Patients, I tell them they can do a free trial for 7 days, but if they don't cancel on the 6th, they will be charged like the real world. So, you know, I've had patients do really well with that. There is quite a lot of research for compression wear and how important that is for proprioception and for pain and POTS. So I've given you the references there. It gets a little bit tricky, just fortunately compression wear is now part of active wear in a way. It's quite trendy to actually have compression wear leggings and things like that, which is great. So the cost has come down. There's some research that shows that the customized is superior, but of course it comes at a cost. It's difficult to fit, doesn't last for necessarily very long if somebody's fluid or weight changes. So you know, there's interesting things there. And then you guys here probably are all over the research about the splinting for the hand, which has come up really, really good. Just briefly about the urogenital side of things, there's just growing information about the link with endo and dysmenorrhea, really. And so it's in our teenagers so important that we are actually addressing their period pain effectively, and there's many, many resources like pelvicpain.org.au is a good one, but there's heaps more at the moment too. And there's a reference there for that. So any questions about that slide before I move on? I know there's a lot there.
Super encouraging to see how much research and progress and change there is.
Yeah, that's right. Yeah. Fatigue is one of the biggest problems, and I've just, you know, there's plenty of resources out there, and I think that interconnectedness with the dysautonomia is vital. But, you know, one reference that is quite good is this, you know, you can see the depth that they go into with pacing, and perhaps we will be able to talk more with Hannah about what she learned from, you know, different professionals she's seen about pacing, because pacing well and appropriately is an art, not a science, I find. Now, I just cut and pasted to try and make things a little bit easier. These are just the heavy shoulder protocol that they used, 16 weeks of 3 times a week supervised exercise. So I think most people would probably do quite well with that level of supervision. And then these were the light ones. Thought that was quite interesting. So if anyone's got a particular interest in that, they might want to look up those papers. Just lastly, the craniocervical instability. So this was another patient that we used with her permission at the conference that we co-presented at. So this patient has classical EDS, and you can see that her skin is very stretchy on her cheek. You can see that her fingers go back sort of 180 degrees. So it's just that next level, really, of hypermobility. And the Sydney group actually have just, you know, they're looking quite a bit at what is normal and what is not normal in cervical range of movement. And there is a paper that they have published, Clifton Chan and Leslie Nicholson, about in people with generalized joint hypermobility, yes, they do have an increased range of cervical extension. Now, Nicole Frost is a physio who is involved with ECHO, and she presented with some of the other authors on that CCI paper in the APA conference. So further information and all the information from the conference is available on her website. So I would hope it's available on the APA website as well, but not sure. And we're nearly there. These are just some useful websites. Leslie Russick is giving a free lecture on Embodia. So I don't know if anyone uses Embodia here, but you can actually sign up to that for free. And her lecture is going to be available for free on an ongoing basis. It works out to be 7 a.m. this Saturday. So you can either attend live or watch it later. So she's just a prolific educator, basically. And then the EDS Society is coming to Brisbane next February as well. And I just wanted to acknowledge Professor Jane Simmons, who some of you might know, who worked at Royal Perth many, many years ago, who's gone on to become a professor and is very well published in this area. Leslie Russick in America, the EDS Society and the Physical Therapy Working Group, which does an amazing amount of work behind the scenes, and they are really inspirational people. And then Echo, if people want to know more, Echo is actually a great platform for case studies and presenting. All right, enough from me. There's all your references. Okay.
Thank you very much, Robyn. What was very evident is that you're very well versed in all of the research and its application.
Cool.
And I don't know about everyone else, but that presentation for me was very overwhelming.
Yes, sorry.
But that's what I'd actually, we've been in discussions, Robyn and I wanted her to try and get across mostly what physios could have access to in terms of resources. So there's a lot of information there for you, which if you're querying anything, you can always go and then, like with the information I'll send through later, you can go and click on a specific thing. There's a lot of review information there as well, and probably guideline related reviews and that sort of thing. And the website, of course. But also, I'm assuming, Robyn, you wouldn't mind people getting in touch as well, just around any potential patients that they might be questioning if they've got concerns or even referrals or that sort of thing.
I certainly don't have all the answers, but I'm very happy for people to brainstorm.
No, no one does with any situation that we're dealing with in Physioland, really. So what we're going to do next is actually, I'm going to ask if anyone's got any questions about anything specific within what Robyn just presented, and we can otherwise flick back through a few slides, or Robyn otherwise can ask specifically, answer like to the question directly.
Oh,
and as people here, sorry, just I'll just wait for the mic.
Thanks, Robyn. This question might get answered through the case study with Hannah, but I was just wondering if I'm a physio, and if I had a patient come in who presented with what certainly looked like hypermobility, possibly EDS, and I didn't feel like I had the knowledge and experience to do a really good initial, and I wanted to refer them onto you, what would that initial assessment, or some of the features of that initial assessment be? Sort of putting numbers, using the spider graph as part of the subjective and that sort of thing.
Yeah, that's a very good question. So it's highly variable, really. I've gone through different phases, I guess, in the last 5 to 10 years of pre-screening any patient that makes a booking to be assessed for hypermobility. But I've just found that sometimes their needs and presentations are a lot simpler than I was expecting. So therefore, you know, hitting them with a lot of stuff is actually not helpful. So what I tend to do now is actually contact them in advance if they're a teenager or an adult, and ask them to fill in the Bristol impact if appropriate. But if it doesn't seem to be appropriate, permission not to. And also just try and get some information in advance from them, because often there is a long medical history, and you know, yeah, sometimes if they come back with a few doctor's letters, I will actually send them the spider graph to fill out. So it just gives me a little bit of an idea of how I can best assess things in that first session. And sometimes people just come because they actually want to know if they've got generalized joint hypermobility or not. So that's a very straightforward assessment of the Bateman scale, and then a bit of a conversation about whether there's any comorbidities present. Yeah. So there's basically, it's still a SOPIA format in a way. There isn't any gold standard for a hypermobility assessment. It's on an as needs basis, and you can see with the diversity that, you know, how people can present. I think it still has to be individualized. Yeah.
Thank you.
Just out of curiosity, hi. My name's Pat. I was just wondering, if you have a patient and you suspect they have POTS, do you usually just with the testing, would you tend to do like blood pressure within different positions, or is there anything else in particular that you do that I guess it's not really seen as common in other areas?
Look, over the years, I've gone through different phases with this, just mainly out of my own interest. So, you know, the normal blood pressure, heart rate monitor, you do collect that data at the same time. If some people can have dysautonomia where their heart rate isn't so much the problem that their blood pressure is, but I sort of feel like that's all getting pretty technical. The POTS Australia website will tell patients, in fact, I had a patient the other day who wanted to assess that herself. And so she sent, apparently there's a sheet on the POTS Australia website that you can download. So she did it herself with all of the blood pressure, heart rate, and then it tells them what to do about that. So I would probably get the patient, because it does take time, because you've got to have them resting for 10 minutes before you then stand them up and then you monitor for 10 minutes. So I would probably try and get them to do that at home and discuss it with their GP. And I think there's a lot more awareness of POTS out there now because of COVID. Yeah, but I always assume that people, if they feel symptomatic, that they probably are in some way. So you don't want to make too much of a big deal about it, but you do want to make sure they're doing the basics of you know, not standing still and being hydrated and things like that.
Hello. My question was around.
Yes.
Sorry, yeah. My question was around referrals. With somebody that does have a lot of comorbidities, do you have a list of some good specialists here who are not only like EDS and POTS aware, but also providing neuro-affirming care?
No. And that's one of the reasons why I'm giving this talk. But I would very much love to be part of that conversation to help direct people appropriately. Yeah.
I suspected.
Yeah.
Right.
Change.
I'll just put another chair around.
Okay.
Yeah, I'll take that. Thank you very much.
Thank you.
You can just use that chair. Yeah, just move a little bit to the left. Thank you so much. Cool. So we're just going to run through, like, I meant to send this out a little bit earlier, but there's been things that have precluded me in doing that. This is effectively just, as was mentioned in the beginning, Hannah's been coming into the practice longer than I have, worked here, and that's for me more than a decade. So, and it's been a little bit longer than that. I'm going to run through how Hannah started presenting into our clinic and effectively her musculoskeletal history with a few other things thrown in around some other symptoms, just to give you an idea of what a journey can look like effectively from all the way pre-adolescence, I guess, all the way through to adulthood. So initially Hannah came in, she had fallen, well, this is when you were 12, apparently you were here at 8.
No, I was younger than
you were young, okay. There you go, you're in year 4 or year 5, so there might be some issues here with details because there's too many notes to go through. But yeah, fell off fell over roller skating, fractured her arm, didn't seem to be anything that was untoward at the time. We just dealt with it as we otherwise would for a fractured arm. And then we're moving forward a little bit with thumb pain a couple of years later, and there was that happened from a somewhat traumatic incident, and that was around the MCP, splintered and settled well. If you look forward a little bit, we had then a number of episodes of subluxation of that same thumb, and during some fairly innocuous things like first episodes while dancing with weight bearing on the hand, next pushing up off a desk, and the third happened while also wearing a splint, which is interesting, of course. Yeah, the weird splint. I don't remember the splint. Which one?
It was that experimental thing.
Okay,
Yeah.
I'm sure we tried lots of experimental things. Hannah's got effectively a shrine to, yeah. How big is this box? There's a very large box of splints that Hannah has had over the years, which she keeps for, I don't know, for memory's sake. Yes. Can't imagine that they'd actually still be working and they'll break apart if you touch some of them. Referred to a hand surgeon, and she had a stabilization procedure effectively where they drill holes through the sesamoid bones and stick them into the metacarpal head, which stabilizes the volar ligaments there. And that ended up working quite well. There was the other thumb that also then that happened to a year or two later. Then 2013 developed left shoulder pain. Wasn't like, I think this is where Hannah was seeing me. I was young and naive probably, and also didn't recognize some maybe hypermobile type symptoms starting to present kind of more broadly. There was then subsequent dislocations. For some reason, they always come in threes. It's always the left side first. There you go. And so if the left side starts, then you can think the other side's probably going to start. And 2014-15 was an interesting period where every single finger in her hands dislocated. And also the left shoulders again. And that was stabilized. Then moving into 2015, left hip pain, no traumatic episode. That was Nicole. Let's still mention Nicole. This is Hannah. This is where hypermobility and EDS might have been started to be thought of a little bit more. Come as she became around 18 years of age, right shoulder dislocated, just rolling over in bed, and then more recurrent dislocations subsequent to that, and therefore the shoulder was stabilized. Hannah was very active in younger years, dancing in particular, and that was very limiting, of course, having all of these body parts start to otherwise be disagreeable. Left wrist pain came on. This was just before this. I think I recall Hannah and I had started to work in the gym a little bit, and that was working out fairly well initially, but it did not end up continuing like that. One of the exercises, I think, ended up leading to a subluxation of the ECU. Yeah. And then that ended up being stabilized. And of course, then there was a number of other surgeries that happened that same year around the both knees and ankles. Both knees. The ankles I don't think have been stabilized. No. Good. Radial head sublux and left shoulder instability noted again despite a previous stabilization. So I think you've had both shoulders restabilized as well. Yes, and the right thumb restabilized. I don't think we're up to that yet. I think that's 2018 or so. There was a little bit of ring splinting there. She had a interesting dislocation at the second and third MTP joints. I think there was a plantar plate injury in there somewhere as well. It was right knee injury, left wrist sprain, left shoulder pain. So you're getting a kind of overall picture here that effectively most joints end up being disagreeable. More recently, in 2022, there was a left cam deformity noted in the left hip, which was resected and labral repair done, which unfortunately led to increased hip instability. So it seemed that the cam was maybe helping the instability, helping prevent the instability somewhat, but that's not there anymore. And that eventually led to a total hip replacement very recently. And otherwise been seeing a pain specialist, and otherwise had been trialing a number of different types of pain interventions, and otherwise is doing working as a nurse, just changed jobs into a job that you seem to love. But yeah, we'll talk more about that as we interview you, I think, Hannah. So thank you very much. Sorry to have you recount all of that.
I forgot half of it.
Exactly. May I invite Hannah up to the front here, and I will get the microphone there. It's going to be easier if we have you holding this, both of you.
Actually, while you're doing that, I was just going to say that one thing I meant to mention, that LDN keeps coming up in the research as being really good for fatigue, low dose naltrexone, and perhaps the method of action, it is actually a mast cell stabilizer. So we'll probably hear more about LDN as well, for pain and fatigue.
Cool. Hannah, would you like to say anything before we get started at all? No?
No.
Okay.
It took me quite a long time to get a diagnosis.
Yeah.
Was kind of told by a lot of specialists that there's no treatment, so there's no point in getting a diagnosis. So it wasn't until I was 20 that I got referred to genetic services and to a rheumatologist and got diagnosed finally, after one of the physios at Flex brought it up with me that I might have hypermobile EDS.
I think I might have said that, or Ian did, or
Bronwyn.
something. Bronwyn. There you go. Cool. Because I also was
2015.
reflecting on what you just said there, and I was probably one of those physios who also said that there might not be any need to get tested because it might not.
Yeah, there was like, what's the point? There's no
Yes.
change, but it has made the biggest difference.
Yes, tell us more about that.
I think having a name for something, like when you're going into a situation like an emergency department, or even just an appointment with a new specialist, not just having to describe all these weird and wonderful symptoms, but actually having a name to put to it. And being able to say, this is what I have, this is how it affects me, rather than having to be like, oh, I dislocated this joint and this joint and this joint, and I've got chronic pain, and then being like, oh, but why? Yeah. It's just very helpful.
Please. We'll be passing around this tiny microphone now.
Sorry. Thank you. Thanks so much for letting us all go on that
No
brief journey.
worries.
Like sort of on that same vein of that was helpful to have the
Yeah.
diagnosis. There was a brief comment on one of the slides that there was perhaps a little bit of resistance initially. If you can remember back then, can you remember sort of what that initial resistance might have been, or was that resistance from the medical professionals?
Yeah, it was. And then
Okay, yeah.
also not really wanting to accept that it might be a condition and it's not just a coincidence that all of these things are happening. And because at the time I didn't know of anyone in the family that had been diagnosed, and hypermobility was it was something that was discussed, but people didn't really know too much about it. So yeah, it was really tricky. Like I had a specialist, my upper limb surgeon, say to me, is like, yeah, I don't know what's wrong, but you're just a funny looking kid on the inside. Like, don't know what it is, but you're just a funny looking kid. And I was like, cool, awesome. So yeah.
Thanks, bro.
Standard Mike.
Thanks, Hannah.
Very nice surgeon.
He's the best.
Yeah.
I love him.
There is the people online.
Oh,
Hello.
hi.
Alex is busy.
Yeah.
Okay. Anyone else? Please.
Hannah, sorry,
Yeah.
hang on, where are we? Video. Yeah. Can you describe what POTS actually feels like to you when it's happening?
Oh, that's really tricky. So
From someone who actually has it, I mean, we know kind of the
if
physiology.
I am in a flare or heading into a flare, like I have daily POTS symptoms, like I feel my heart racing and a little bit of chest pain, and have to get up quite slowly because I can feel a bit dizzy, like my vision goes black, things like that. But it's really weird. Like when I'm going to go into a really bad flare, I get this sense of impending doom, like something's wrong, but I don't know what. And then it's like really feels really deep inside my body. But then in a couple of days, I'll go into a POTS flare and I'll pass out and I'll be like, oh, that's why I felt like that.
Yeah.
It's really strange. And I think it's reported quite often with POTS patients and other cardiac patients, that kind of sense of impending doom before an episode.
And does that change? So say throughout a sort of typical day, but maybe around a flare up, does that kind of, are you okay once you get settled in the morning? Does it kind of get worse throughout the day, or does it kind of match up with fatigue? Or
it honestly depends on what I'm doing. Like the heat really, really affects me. And if I'm on my feet a lot.
I think you're muted, Jay. Jay, you're muted.
Jay, we can't hear.
Did you unmute yourself?
Is that better, everyone?
That's better.
Yeah, my question was just around that feeling of that impending sense of doom, and was there any kind of like dismissiveness around like, oh, that's just anxiety, or like was that sort of like pushing towards a mental health diagnosis versus exploring what other causes there might be?
Luckily for me, not so much, but I know it is the case for lots and lots of patients, because my POTS diagnosis came after I fainted, hit my back on the bathtub and ended up in hospital. So it wasn't like I went to a cardiologist or I went to my GP. I was kind of ignoring it. And then the episode happened and I kind of had no choice but to deal with it. And I was just really lucky. The doctor that admitted me through ED was really, really good and put me in touch with my current cardiologist. And we just went from there.
Can I ask, Hannah, what your medical support team looks like?
Yes. Yeah. So at the moment, it's lots of physios, a pain specialist, a cardiologist, and then orthopedic surgeons as needed. And I have a gastroenterologist as well. Yeah.
No rheumatologist still in that
No,
mix?
not currently, because I was diagnosed by genetic services, which I know they don't see many patients with hypermobile EDS anymore, but at the time that was the place to go to. And then I did see a rheumatologist shortly after I was introduced to Robyn, and she kind of referred me to the pain specialist and said, because you have a diagnosis, there's not a whole lot that they can do. Oh, yeah.
And you also didn't mention any psychiatric or psychological support services?
I don't see anyone currently because I just haven't found it helpful for me. Yeah.
Yep. That's a pretty impressive team nonetheless.
Good question.
Hannah, hi, I'm Carol Gorge. I'm
Hi.
a physio at King Edward, and we do see quite a few patients
Yeah.
who sort of fit this picture. And I'm just wondering, with the long period that you've had and all the interventions, do you feel like you're getting to a point where you can function with confidence within the constraints of,
Yeah,
or
definitely.
do you feel like it's still a lot of your effort has to be avoiding those sort of aggravating factors?
Yeah, a lot of my effort does go to avoiding aggravating factors, but luckily I've kind of just weaved it into my life, and using things like pacing, I've got to where I want to be. And I'm just, prioritize the things that I absolutely have to get done and just take things really slowly.
Just on that,
Mhm.
are there accommodations at work that you have to make?
I try not to, but my workplaces in the past have been really good with cutting down hours and things like that if I need sick leave for surgeries, things like that. But I've kind of, worked in areas of nursing that work within my limitations. Yeah.
This is a question to both Hannah and Robyn. So I noticed in your history, it's all peripheral joints. So it's arms, legs, hands, etc., fingers. And I know the hypermobility test includes trunk flexion, palms to floor. So I was wondering, Hannah, have you had any experience of back pain, neck pain, headaches? And what's the incidence, Robyn, of spinal joint issues compared to peripheral joint issues?
Yeah. I've got back pain issues that kind of just deal with. And then same with neck and migraines that I think they're probably cervicogenical, can't speak, headaches. But yeah, so I just deal with them with heat packs and things like that when they come along.
Real mixed presentation, basically. I find a lot of patients have the chronic widespread pain over their spine. Not so much low back pain unless perhaps they're very active in dance or gymnastics. So there might be more of those dance-related hyperextension sorts of injuries. But yeah, more pelvis, sacroiliac joint. We know the sacroiliac joint, it doesn't move very much. We know that, but in pregnancy and in hypermobile people, it probably moves a little bit more than in other people. So, I do find that symptomatic sometimes, probably more so than low back if they're not a dancer. Yeah. And then the migraines are, for some patients, they are one of the biggest things. I think that whole area of research about the upper cervical instability is going to give us a lot more answers about those that, sometimes present really complex with the chronic pain, maybe even the neurological, the FND, sort of the cervicomedullary syndrome, and how that gets assessed is not yet really clear. Yeah, basically.
And just following on from that, does the hyperelasticity extend to intervertebral discs and that sort of thing?
That's a good question. I don't have any information on that, but I guess because it's soft tissue, we know that, if you break down at a molecular level, you're looking at the cells. So I would think that maybe there is, yeah, but I haven't come across that in the research. Yeah.
Just on that point, I saw an interesting paper a little while ago that had imaged people who are contortionists, who are more likely to have hypermobility or EDS, for instance. And when you look at their range of movement in their spine, it's normal. Like, this is through fluoroscopy as well. So it's like looking at the actual bones, which was interesting. That's not what they expected. So I don't know, it might be only it was a very limited number of people because you can't do a big study on that sort of thing. But yeah, so who knows? It's hard. I guess you've got the facets there that are going to limit how far things can extend to some degree, although they might pivot over the top in some people. Not sure. Questions? Sorry. Yeah, there was someone online who was about to ask a question.
I'm Robyn and Hannah, Nola Mattingly here at Royal Perth. Great presentation, thank you very much. I think you said when testing the blood pressure for POTS that you kept them upright for about 10 minutes. So if that's correct, Hannah, my question to you is, when you stand up, do you feel the effects of POTS immediately, or can it be delayed over 10 minutes or whatever?
It honestly depends on how bad my symptoms are on the day, but quite often I will feel them immediately. But then they can worsen over that 10-minute period. Yeah.
So it's not like you can stand up and feel okay and then all of a sudden not.
Sometimes I will, yeah. If things are going really well for me, all of a sudden, like I could be walking down the street and all of a sudden it would hit me.
Okay. Scary. Thank you.
Annoying is
Very
kind words, I'm sure. Anyone else online?
I have a question. Hannah, you mentioned that you see a couple different physios. I guess, what's the role of the physiotherapist for you in your life?
Okay. So
What purpose do they kind of?
Ian does from the elbow to the fingers. Jay does like big post-op rehab, and then the other physios do clinical Pilates. Pretty much.
And you could probably, what role Robyn played?
Crisis management.
Pretty much. Health, maybe that.
Yeah, women's health and crisis management.
Yeah, and I guess probably following up from that, like, why is that important to you? Like having those things managed?
It's really it's just those main support people that I've had consistently in my life for a very long time. They know me, I can be completely open with them, but they're the things that I feel like my clinical Pilates keeps me overall stable. And then, just having those people that I know I can turn to if, excuse my language, but shit's hit the fan, is really, really helpful.
I think you've got a massive role to play with this population. I think we're the key ones that can support these patients. And, a lot of the patients I see, it hasn't come up yet, that have got medical trauma, PTSD from their interactions with health professionals. And so I just think that anything we can do to increase awareness and support these patients is well.
Follow-up question around clinicians. What have been, you've had many interactions with the healthcare, I'm not going to say system, I'm going to talk about professions here because there's different system problems. And from a clinician perspective, what are some of the barriers you faced, I guess, and yeah, just broadly speaking.
Just having absolutely no knowledge of hypermobility or Ehlers-Danlos loss whatsoever. I had a surgeon say to me once that I must be the only person in Australia with it. Oh my goodness. We can probably guess who that was. Jay.
Let's not go there.
So yeah, just completely just no awareness whatsoever. Not willing to learn because they don't deem it is something that they need to know about or something that will affect their patients. And people are scared of it. They're terrified of treating it in case something goes wrong or they, fear surrounding it, mostly from medical professions. Or people labeling, the other thing is people labeling people with hypermobility as hypochondriacs as well. So,
I have a question
Oh,
for
sorry.
Hannah. Oh, you go.
No, you go. I've already asked.
It was just more around the financial burden of this. From my understanding, it sounds like you've done a lot of this privately, and what financial support you've had, or is there any funding that you've been able to access, or have you accessed the public health system? How has that been for you over this huge journey of yours?
it's incredibly expensive. I'm lucky that I've had a lot of support from my family. I've got pretty good private health insurance, thankfully. But I don't think I would be as functional as I am if I was fully in the public system. Unfortunately, because there's just not access to the resources as frequently as you need them. The only specialist I currently have publicly is my gastroenterologist because he feels that he can treat. I saw him privately initially, but he's moved me over to the public system because he's got more resources at Fiona Stanley. And then sometimes my pain specialist will do things at Charlie's for me if the wait list is shorter. But yeah, it's incredibly expensive. Accessing like disability support and things like that is really difficult with EDS, and also the NDIS is just pretty much impossible to access if you have a connective tissue disorder.
Okay, they didn't accept your plan. Did you put one through? Yep.
Yeah.
Yep.
Yeah. So the only support I've really like financial support from the government I've ever had is like if I've been off work for a big surgery, I've been on job seat for a couple of months. But that's it.
Jared?
Do you think there's any gap in services? Like, is there something that you kind of wish that you had that you don't have access to?
Robyn, before you come up with a considered response, I'll just say that there was a paper that was published in the UK, which I didn't put in your references, actually, a little bit provocative, but it actually was a survey of patients and showed that 99% of patients with EDS and HSD have unmet medical needs.
Yes. Yeah, pretty much.
Where do you start? Yeah.
Where do I start? Pretty much. There's so many unmet needs and areas that could be better managed. I know in other countries like the UK, they have connective tissue specific clinics that have that multidisciplinary team input. But one of the biggest gaps that I've noted is probably communication between healthcare professionals. Like no one talks to each other, and it's kind of up to the patients to be able to let their specialists and everyone else know what's going on. Yeah,
I think you've just highlighted the primary problem in how people manage, or how clinicians manage their patients. I think that's just broad.
So people do want to pursue that further. There is actually in Toronto a clinic called the Good Hope Clinic, which has got a really good model of care. I think it's private, but they actually detail how they've done it, and they fast track people into either, gastroenterology, neurology, pain management, it's done really well and it's all out there.
We've got a few ED physios online, I think. just wondering if you can maybe describe what your experiences might have been, and what good care looks like, what care could look like if it was optimal.
Yeah.
Might have to get
Broadly, reasons that you might go there, what private practitioners might need to know about sending their patients there.
Yeah, I went to ED for everything from a dislocated joint, a fracture, to a pain crisis, to running out of options and getting sent to ED because no one can work out what's going on with me. But it's best to, if you're sending someone, to send them with a letter that details their conditions. So it's not just coming from the patient, it's coming from someone else as well, because they're, especially doctors, they're more likely to believe you, which is sad to say that, but yeah, they're more likely to take you seriously, believe you if you've got some supporting documentation with you. I've had really good experiences at Fiona Stanley with advanced scope physios treating dislocations and fractures and things like that. Yeah, and I feel like they're a lot more supportive and understanding than if you were to go and be seen by a doctor for the same issue, and you get seen a lot faster. Things are a lot smoother, and it's, yeah, just a lot more pleasant.
And do you have what do you take when you go other than a letter from the physio? Do you have medical information in a big old file? So you don't want it to be too big, just it's big enough.
It's a lever up file, pretty much with everything that's important. Yeah, that I take with me.
Yeah.
Yeah.
Can I ask one more question? Hannah, have you found any particular exercise or activity that's really helpful for you? Pilates. Yeah. As in, it covers everything, general strengthening, flexibility in a controlled sort of setting.
Yeah. Sort of, yeah, that's supervised exercise.
Yeah. And supervised is better for you
Yeah,
than
I tend to put myself. I've got really
okay.
I can't tell if I'm hyperextending unless I'm looking around.
Yeah. Thank you.
Just extending on from that, we've tried something like I personally don't do Pilates. I'm not trained in it. You're aware of that. What was your experience doing the resistance training? Like, we did the gym for a little while there. It was working out well. Fair enough. So it's the location and how it feels. Yep.
Like, I just struggle with my motivation a lot with the gym, but I just don't enjoy, because like growing up as a dancer, I don't really enjoy that kind of exercise. But I love it.
That's fair. I've moved away from being so bloody minded about things. Sorry. Is that better? Is that different? Hello? Yep. Okay. I'm just wondering if this is running out of 1 second. This mic is gone. How did that happen? Okay, we're gonna share a mic. There we go. How did it feel doing the resistance training though, rather than Pilates, like, body weights, that sort of stuff?
I find it harder.
Yeah.
Yeah,
Okay.
a lot harder. I find it a lot harder, a lot more painful, and I struggle with the movements a lot more. Yeah. Than I would with Pilates.
There's good research for hydro as well, but we've never really been able to do hydro. But just because it actually, the compression of the water obviously increases the stroke volume and helps with POTS. But from a safety point of view, obviously people have to be supervised or have a person with them, particularly not only in the water, but when they get out of the water, because that's when they often get the big blood pressure changes. But hydro has actually helped many of my patients.
Anyone online?
Hannah, hi, I'm Nikki Fortescue from Royal Perth. Thanks again, Robyn and Jay. This has been wonderful. We have links with Jane, who's high up the food chain, who has had to go off to ED. So you did touch a bit earlier on flare-ups and stuff. I'm interested, you know, in you describing this feeling of doom when you can feel one coming on. Do you have an actual flare-up plan? And I'm also interested in medication and how much you use that and what sorts are helpful for you.
Yep. Is that in terms of pain or POTS or?
Well, in fact, everything, because, you know, you may be on a bloody long list.
Yeah, I am on a ridiculous amount of medications, mostly pain and for my POTS. I have a really good cardiologist who's got me. We took a while to work out a plan that works best for me, and I was ending up in hospital a fair bit, but now I am on medication and then I'm on saline infusions. It depends on the weather and how I'm feeling, but it could be anywhere from monthly to weekly. Yeah, just depending on how often I'm needing them and how I'm feeling. My specialists are quite good. They kind of understand that I know what's going on with my body and they're willing for me to kind of take the reins in some of the situations. And then same with my pain management. I've got my PRN medication that I can take when I need to. If I'm in a flare, I try and avoid it as much as possible. But then recently for my flares, we've been doing ketamine infusions, which has really, really helped in the long term as well with my sort of central sensitization. That's definitely helped a lot. Yeah.
So do they get you on lozenges or anything like that, or you just...
Yeah, that's what I have for my breakthrough pain, if needed.
What's your baseline pain meds?
I'm on Palexia in the morning and the evening, gabapentin and Cymbalta. Yeah, and then the ketamine lozenges if I need them for the breakthrough pain, which I try and avoid because they make me feel a bit weird. A lot weird, yeah.
And you mentioned saline infusions.
Yeah.
I mean, do you sort that self out for yourself at work, or how does that...
I have an infuser port because it got to the point where I couldn't go more than 2 weeks without going into a massive POTS flare and ending up in ED and then being admitted for a couple of days to sort myself out. So I ended up with a central line and being able to access my saline infusions at home.
So,
which I know lots of specialists are reluctant to do, but it kind of got to that point where I couldn't do anything else.
Yeah. So for me, this brings up I guess the other side of the spectrum, in that we've heard from you, Hannah, who you've had good family support, you've been well educated, you are, you know, very invested and involved, but in a positive self-management way to try to live with this condition. Whereas through the public system, we end up seeing the people who have none of that. So they don't have the family support. They've often been, you know, they're not with their families anymore. They are, you know, going from person to person in the public system with 1 to 2 year waiting lists. And it's just appalling. And so by the time we do see them, they're psychological, psychiatric mess, as well as feeling unvalidated and all of the other things that go, and probably have a lot of different system issues that still haven't been diagnosed or picked up. And so for me, it's quite refreshing hearing your story and seeing, you know, I mean, you've probably been to hell and back over your lifetime so far, but you know, it's great to know that there are people like you out there who do learn to manage it, because we do have very limited resources in our physio department as to how often we can see people and what we can do with them, and then they just can't afford to go off and do their own Pilates or that. So, and they'll have very, very fixed beliefs about what's happening with their body, and you know, if we try and get them doing anything, that they're going to sublux or dislocate. And that's where I had my fear of, you should know your body better. Am I going to cause harm? Anyway, I'm getting off track. I just wanted to say well done, congratulations.
Thank you.
And presentation. And if you've got any comments about how we can better do things in the public system, I'm all ears.
Yeah, I don't really, because I haven't been in the public system that often, but it's, yeah, just picking up those little things and putting those referrals in place. It's like I was having a conversation with Robyn the other day with all of my presentations as a kid to Princess Margaret. I probably should have been reviewed by someone, but it just never really happened. Yeah.
Can I ask a question kind of on that note?
Yeah.
Can you guys hear me? I finally got my microphone to work. Hi, Robyn.
Marika.
So,
Hi, Marika.
hey, so I work at King Eddie's, and obviously we see a huge population who come through our clinics, to the point that I'm finding now if I screen every complex urogyne, bladder overstretch injury, and all of our patients with pelvic pain and endo, the prevalence of hypermobility is extremely high. The question I guess I had for Robyn is, now that we're sort of screening it and obviously seeing it more, and we're going to actually do a study, with the endo team to start screening all of their patients who come through the clinic, just to look for prevalence again. But do you think, in what areas do you think within physiotherapy or patient presentations do you think we should be basically actively screening? Because what I'm finding is that I'll say to patients, are you bendy? Are you hypermobile? And they'll say, nah, I don't think so. And then you'll do a Baton and they're actually really hypermobile, but they've never necessarily dislocated joints. It wouldn't have ever necessarily come up, but then they've got all those systemic issues. And, we look at that spider and it's, there's a lot of stuff going on. And I'm just wondering what your thoughts are with patient presentations and who we should be screening pretty much as standard, because it's pretty quick to do.
Thanks. That sounds great about the study you're doing at King Edward's. It sounds wonderful. Look, we're caught between a rock and a hard place. We don't want to catastrophize. We don't want to make something big out of something that's not really relevant. But I think that, what we're learning is that you're right, it is really quick to do a Baton. And so, there is just some, I think we can all be doing that on our patients and trying to help them to get, what I would like to see is just better, accurate diagnosis from the medical professionals. I mean, Hannah's case is extreme. She's one of the 1 in 500, but there's a lot of others out there who are just on the spectrum who don't have the fractures and the dislocations. They just have pain and hypermobility and some of the comorbidities. So I think if we can help diagnose them better on the spectrum and have the medical profession doing that too, we can help prevent some disability that happens just through, lack of awareness of the condition and all of that.
To suggest we cut it off there, considering we're about 7 minutes over time. So thank you everyone for, yes, they're on this screen. Okay, thank you everyone for coming in, both here at Flex and online. Thank you to Hannah, most importantly.
You're very welcome.
Thank you so much for coming in, both as well, Robyn. If there is any follow-up questions, you're welcome to flick them through as an email, and we can do our best to try and get you a response. So otherwise, next month we'll have me presenting on shoulder dyskinesia and when it's when it's relevant and how to manage. So otherwise, be on top of the mailing list and check your emails in about 4 weeks' time. Thank you everyone. I'll see you next month.
Thanks. Please leave.